This animation demonstrates the difference between a successful and a failed fetal to neonatal circulatory transition. On the left, a normal newborn transition routes blood directly into the lungs for oxygenation. On the right, a term or post-term infant experiences persistent pulmonary hypertension of the newborn, or PPHN. Here, the transition completely fails, and blood bypasses the lungs to mix directly into the systemic circulation. The underlying physical law dictating this failure is a severe pressure imbalance. Notice the heavy mechanical scale on the PPHN model. Pulmonary vascular resistance remains excessively higher than systemic vascular resistance, forcing the directional flow of blood away from the pulmonary bed. Because of this steep pressure gradient, deoxygenated blood has only one way to go. It is forced to shunt right to left, pushing straight through the patent foramen ovale and the ductus arteriosus. This initial right-to-left shunting strips the systemic circulation of oxygen, creating profound hypoxemia. That resulting hypoxemia then acts as a powerful physiological trigger, causing the pulmonary vessels to physically constrict even tighter. A self-reinforcing cycle takes hold. The progressive vasoconstriction continues to raise pulmonary vascular resistance, which increases the right-to-left shunting, decreases pulmonary perfusion, and severely worsens the hypoxemia. Managing PPHN is not accomplished by simply forcing oxygen into the infant's lungs. It requires a targeted physiological escalation to carefully dismantle this exact pressure gradient, all without causing iatrogenic lung injury. To break the cycle, clinicians must first pinpoint the precise anatomical location of the right-to-left shunt before attempting to manipulate the vascular resistance. The clinical starting point is often a term infant presenting with refractory hypoxemia. We confirm this by administering the hyperoxia test. If 10 minutes of 100% oxygen fails to elevate the PaO2 above 50 to 70 torr, the hypoxemia is definitively refractory. 3 primary etiologies drive this presentation: hypoxemic vasoconstriction from asphyxia or meconium aspiration, hypoplasia of the pulmonary vasculature, or idiopathic structural abnormalities. To isolate the physical shunt, we rely on the specific anatomy of the newborn's vessels. This diagram outlines the neonatal aortic arch. The brachiocephalic artery branches off preductally, supplying the right arm with oxygenated blood. The lower extremities receive deoxygenated blood, actively shunting through the ductus arteriosus. An SpO2 gradient of 5 to 10% confirms this shunt. While a severe SpO2 gradient confirms right-to-left shunting, it cannot definitively rule out cyanosis caused by severe congenital heart disease. For that, echocardiography is the mandatory gold standard. It is the only tool that can visually confirm the right-to-left flow, accurately estimate pulmonary artery pressures, and exclude structural congenital heart defects. Diagnosing PPHN is an exercise in proving the physiological right-to-left shunt exists. Once confirmed, the clinician must pivot immediately to optimizing the infant's systemic environment to physically oppose this dangerous right-to-left shunting. The critical first step of systemic optimization is eliminating environmental factors. Clinicians must aggressively correct cold stress, correct metabolic acidosis, hypocalcemia, hypomagnesemia, and hypoglycemia. Physical stress also acts as a powerful vasoconstrictor. Pain and agitation trigger catecholamine release, drastically increasing pulmonary resistance. Minimizing stimulation and providing adequate sedation, typically with an opioid like fentanyl, is essential. Concurrently, we actively manipulate the systemic vascular resistance to push back against the right-to-left shunt. This requires fluid therapy and inotropes, like dopamine, to maintain a mean systemic blood pressure above 45 to 50 millimeters of mercury. When transitioning to mechanical ventilation, clinicians face a major pitfall: the instinct to combat severe hypoxemia by simply turning up the peak inspiratory pressure, or PIP, on the machine. Looking at this cross-section of a single alveolus and an adjacent pulmonary capillary, we see exactly why overexpansion is dangerous. Aggressively hyperinflating the alveoli physically flattens the capillary. This mechanical crushing directly spikes pulmonary vascular resistance back into the red zone. Blood flow backs up, worsening the shunt and accelerating the cycle of failure. For neonates with severe parenchymal lung disease who require high pressures, high-frequency oscillatory ventilation, or HFOV, is recommended. It minimizes barotrauma and enhances the delivery of subsequent pulmonary vasodilators. Mechanical pressure limits out quickly and can actively harm the patient. When standard ventilation fails to correct the hypoxemia, clinicians must escalate to targeted pharmacological vasodilation to open the pulmonary bed. The critical metric for this escalation is the oxygenation index. An OI climbing greater than 20 to 25 signals the absolute need for a selective pulmonary vasodilator. The preferred agent is inhaled nitric oxide, or INO, typically initiated at 20 parts per million and delivered seamlessly through conventional ventilation or HFOV. This microscopic view demonstrates the drug's physiological mechanism in action. Nitric oxide diffuses from the alveoli directly into the adjacent vascular smooth muscle, triggering a rapid wave of relaxation that visibly widens the vessel's diameter. Inhaled nitric oxide is vastly superior to systemic vasodilators. Because it is inhaled, it strictly dilates the vessels immediately next to ventilated alveoli. This perfectly matches pulmonary perfusion to ventilation without causing dangerous drops in systemic blood pressure. Therapy requires mandatory, strict monitoring. Daily serum methemoglobin levels must be kept below 5%, and the drug must be weaned slowly over 12 to 48 hours to prevent sudden rebound vasoconstriction. If the infant does not respond to INO, or if it is unavailable, phosphodiesterase inhibitors like sildenafil or milrinone are utilized to promote that necessary vasodilation. Inhaled nitric oxide successfully bypasses the mechanical limits of ventilation to lower pulmonary resistance. Yet it is not a cure-all, and clinicians must be prepared for the infant who continues to decline. Intractable PPHN occurs when an infant continues to fail despite an optimized systemic baseline, high-frequency ventilation, and inhaled nitric oxide. The absolute threshold for final escalation is reached when the oxygenation index climbs greater than 40. This schematic illustrates a neonatal ECMO circuit. An OI greater than 40 indicates a total failure to medically lower pulmonary resistance, mandating the use of extracorporeal membrane oxygenation. Deoxygenated blood is drawn away from the failing cardiopulmonary system, passes through an external oxygenator, and returns as oxygenated blood, completely bypassing the high-resistance lungs. ECMO candidacy relies on strict viability criteria: an age of at least 34 weeks gestation, a weight greater than 2,000 grams, reversible lung disease, and an absence of major intracranial hemorrhage or untreatable congenital heart defects. Because tissue oxygenation is rapidly deteriorating at this stage, if ECMO is indicated but unavailable on site, clinicians must arrange immediate transport to a specialized center. PPHN is a high-stakes failure of neonatal hemodynamics. It is a physical collision between an impaired pulmonary bed and an unyielding pressure gradient. Survival relies entirely on isolating the physiological shunt, optimizing the metabolic baseline, avoiding the mechanical trap of alveolar overexpansion, and systematically applying localized vasodilators. Mastering PPHN requires treating the pulmonary vasculature and the systemic vasculature as two sides of a physical scale, constantly working to tip the balance back to a normal postnatal state.